welcome all of you to this Global Genes webinar on leveraging a rare disease center of excellence. I'm Daniel Levine, principal of Levine Media Group and host of Global Genes Rarecast. And it's a pleasure to be moderating today's panel. We have a great group of panelists today who have experience setting up centers of excellence, and they'll share their insights from their experiences. Our panelists are Carrie Luther-Rosbach, President and CEO of the Tuberous Sclerosis Alliance, Mohammed Makati, Chief of the Division of Pediatric Neurology at Duke University, and Kanalo, Founder and President of the Turner Syndrome Global Alliance. Thank you all for joining us today. I'd like to thank today's sponsors, Alexion, Genzyme, and Shire for their support for today's webinar, and the staff of Global Genes, and in particular Katie Mastro for her great work putting together and coordinating today's program. This webinar is meant to be interactive. I encourage people watching this to use the instant messenger at the bottom right-hand corner of their screens to send questions for the panel as we go. I'll do my best to work these questions in or save it for the end. We'll try to save some time at the end for questions from the audience. Today we're discussing centers of excellence, what they are, why they matter, and what it takes to establish one. We're going to use the term center of excellence, but it's a term with which not everyone is comfortable, uses for a variety of reasons. And we're going to use that term, but let's carry the Tuberous Sclerosis Alliance of excellence are disease focused. It's the complexity of these conditions and the range of needs that patients have that is one of the things that make them so valuable. I think to understand that, it would be good to start with a little understanding of tuberous sclerosis. Can you take a minute and explain to our audience what tuberous sclerosis is, how it manifests itself, and the range of medical services a patient will typically need?
And thank you so much, Daniel. Tuberous sclerosis complex, otherwise known as TSC, is a genetic disorder, a rare genetic disorder that causes tumors to form in vital organs: brain, heart, kidney, liver, lungs, and skin. TSC affects about 1 in 6,000 live births, 6,000 Americans, and more than 1 million people worldwide. No two people are affected in exactly the same way, even identical twins. We know that the neurological manifestations are often the most devastating and affect almost everyone with TSC in some way, from mild to severe. It is also the leading genetic cause of epilepsy and autism, and individuals with TSC require a team of healthcare physicians, such as neurologists, cardiologists, nephrologists, dermatologists, pulmonologists, audiologists, occupational, physical, and speech therapists, and of course, very strong partnerships with educators. In 2011, the TS Alliance hosted a TSC Clinical Consensus Conference, and at that time we updated the Clinical Consensus Guidelines for diagnosis, surveillance, and treatment in TSC. And so the rules of medical care that you're talking about, guidelines on those can best be found within the Clinical Consensus Guidelines, which, if anybody is interested, they're on our website at tsalliance.org/consensus.
And do you use the term Center of Excellence?
We use the term Center of Excellence. We provide a designation as a TSC clinic, and TSC clinics can also obtain a gold standard level within that designation.
And why don't you use that term?
Because centers have different types of services that they offer. We prefer to use core standards. So for instance, we have 10 core standards a clinic can meet. A gold standard would be similar to a center of excellence, but we just prefer not to use that term.
Okay.
So if you are 10 core standards that we use for a TSC clinic designation, 7 of them are clinical, and we can move to the next slide so we can show those. So first is the directors need to have medical certification in their country of clinical practice related to one or more aspects of TSC. A co-director of a clinic can be a medical doctor, a PA, a nurse practitioner with certification in their respective professions. Each of our clinics, the clinic directors need to serve on our professional advisory board. Each clinic needs to have at least 3 core specialties, such as dermatology, nephrology, or urology, as well as neurology. It's a children's hospital because of involvement in heart tumors and TSC. We want to have a cardiologist involved. And in the care of women who might develop a pulmonologist is definitely a requirement. We want there to be a comprehensive evaluation of new patients and recommended follow-up following the consensus guidelines. We like our clinics to work as a team to provide comprehensive care, and necessary to consult with other TSC directors or subspecialists. And then the staff of the TSC clinic should have someone who coordinates the care among all of these different types of physicians. And then the staff of the TSC clinic, again, should be involved in educational resources, so have an educational requirement. That's educating the lay public or and other healthcare providers or individuals with TSC and their families. Then we have 2 core standards that relate to partnership. They should be a part of the TS Alliance. We have 34 branches of our organization across the country, and we ask that they partner with that community alliance and to provide educational services at least 3 times per year to the general public through the community alliance. There are also 7 additional gold standards that can be seen on the slides that are being shown now.
And in terms of commonality, when you look at these core standards or you look at a center of excellence, are these things you consider essential as a minimum to have that critical mass?
Yes, they definitely need to have at least 7 of the core standards to even qualify as a TSC clinic.
So when you, roughly, how many of these centers are there for tuberous sclerosis?
49 TSC clinics, 47 here in the U.S. and 2 in Israel. We have a new global partnership there, so there are 2 clinics in Israel that are designated.
And did these centers form independently? Did your organization have a role in establishing them?
It's a really excellent question. In some cases, it was a physician who saw many patients in a general geographic area. Other times, it was a compassionate parent or individuals with TSC that worked with the healthcare provider. And then there have been times that the TS Alliance has identified an area of the country that was not being serviced. And so we worked with our professional advisory board to identify a potential physician to start a TSC clinic.
And typically, is there a number of patients that one of these centers would serve?
No, we have clinics that range from 15 patients to over 500.
So, and in terms of clustering them, how close to the patients do they need to be? Is there some relationship between geography and access?
There's definitely a relationship between geography and access, but if you look at the map that's up now, you can see there are areas of the country that are trying to identify a new TSC designated clinic, because you can see that there's a specific area kind of right in the middle of the country that definitely needs some service.
I want to remind our audience that they can instant message questions as we go for our panelists, and we'll try to work them into the conversation as best we can or save them up for the end. Let's bring Mohammed into the conversation here. Mohammed, you've established an automating hemiplegia program at clinic at Duke. You don't use the term Center of Excellence either. Why is that?
I think we went over that. It's kind of presumptuous in a way to say that, although we of course, aim to be to achieve excellence in all what we do, and others also do that. So to the background about alternating hemiplegia, it's a much less frequent disease as compared to tuberous sclerosis. It occurs 1 in a million, so that's in a way part of difficulty and the problems that the patients have, because not too many physicians are familiar with order. But like tuberous sclerosis, it is a complex disease, and that's a key. These patients, like we have kind of 5 diseases all put in one. They have they have symptoms of cerebral palsy, so difficulty with motor development, motor control. They need physical therapy, occupational therapy. They also have episodes of hemiplegia, which is paralysis. They get paralyzed for minutes to hours to days, sometimes weeks on one side or the other, and or both sides. You can imagine a small child who is paralyzed for these periods of time and cannot do anything, is fully awake, but cannot move, and it's terrifying to them. They have episodes of epileptic seizures, so they have to deal with that too. They have also developmental delay and hyperactivity, and that also causes problems for them and for their caretakers. They also have episodes of dystonia, meaning spasms with distortion of the position, and painful dystonic spells also occur. So they have to deal with that too. And so the care of these patients is very complex. You can already see that there are multiple problems that that have to be addressed. And together, they have also problems with their sleep very often, and also they're predisposed to early unexpected death. So apnea is a problem when they're paralyzed or when they're having seizures. So you need a multidisciplinary team, and that's why we developed the multidisciplinary clinic. The gene was discovered that causes most of the patient cases was discovered here at Duke, and we had a long-standing interest in this disease, so we started the first multidisciplinary clinic, and we are cooperating with centers across the world, really, for that disease.
Well, what resources did you bring together here, and why is that type of coordination of care so important to this type of patient?
Yeah. The resources are this multidisciplinary approach, and it's not just with the physicians, but also with the family associations, and also with other physicians dealing with this disease, because we all can learn from each other. And it very quickly becomes dollars and cents, because in order to put it together a multidisciplinary team, this is costly, and we addressed it in 2 ways. One, by motivating people in the medical profession and the support services. So we have a huge team, and initially we just met together and talked together about these cases, and everybody was convinced that to address the problem, you need the multidisciplinary approach. So people came together without necessarily having extra funding initially. And then the other part is to partner with the family association that can provided logistical support, the Cure AHC Foundation, and also can provide financial support in addition. So family associations provide both.
So I think of, sometimes patients driving the creation of these centers, sometimes advocacy groups, but in your case, this was driven by the doctors themselves. Is that correct?
No, it was a partnership with the Cure AHC Foundation.
So how did it come about that you were able to create this center?
Well, just resources that are already available at Duke, but the partnership with Cure AHC basically provided the contacts with the patients, the facilitations for the patients to travel to come to our center. The Cure AHC has been able to support the basic research available for that are also performing. But for the clinic itself, basically it has been resources from Duke that we have used by convincing people that it's important to pin and provide that kind of support.
Well, was there a bit of a sales job internally to Duke to go along with this, that it was justified in setting up this clinic?
Absolutely, absolutely. And I think when people realize how important things are and that they're making a difference, you can go a long way with that. But at the same time, you have to look at the other part, and the long term, I think the partnership with CureAC is very important for us, has been from the beginning and will continue to be.
From a financial point of view, was this a difficult sell? Did it require substantial investment on the part of Duke, or was that side funding?
Well, I think it's not huge, no, because you can be creative in incorporating the needs of the patients into your daily routine. You are able to provide them with what you need. I think if we are able to enlarge the scope of the then there may be a need for more financial support, but so far we have been able to manage with the resources that are available, and by incorporating the needs of the patients into what we are already providing for other patients.
You talked about CureAC. How closely do you work with them? What role have they played in creating and supporting the work of the clinic?
Well, they a patient advocacy group, so they basically have repeatedly expressed to us the needs. That is very important because in order to create something meaningful, you have to know what the needs are. For example, the need for behavioral, the need for physical and occupational therapy evaluations. So that's one. Two is by making it known that this clinic is available, by piloting initially the procedures for the clinic were not well set up. We were mavericks starting this clinic, unlike the TS complex, where there are standards that people, if somebody wants to start a clinic, have the standards that were so eloquently described. So we had to pilot a few patients and develop those procedures, and they were very helpful in giving us feedback about how things are going, what is needed, so forth. So that's the second contribution that they made. The third is, as I mentioned, make the service known to patients, because they are contacted repeatedly, being the liaison with the patients, helping patients in the logistics of coming to North Carolina and being evaluated. So all that was very critical in the initiation and success of the clinic.
So how far do patients travel to come to the clinic, and how many patients do you serve?
We have had patients coming from as far as South America, Caribbean, and we, as I said, it's a rare disease, so we have seen about 24 patients for full evaluations, and have had many more either by a limited evaluation or we do a lot of telephone consults with the physicians taking care of these patients. Like somebody may contact us from California or from India or from Europe and Australia, New Zealand, and we would consult with their physician to give them advice about what we think may be going on, and giving them some of our experience with the disease.
Is clinic self-sustaining? Is there pressure
Yes.
to be so?
Yeah, now it is the way we set it up. It is self-sustaining.
So, is there a research component to what you're doing here at the clinic, or is it purely a clinic?
Yes, research component. We have a database a clinical database that we've incorporated. Again, the support for that is coming from internal funds from Duke that we were able to again creatively use. There is a basic science component where we have a mouse model for the disease that we are studying that CureHC is supporting financially. We also have additional funding other than the CureHC that we use for the basic science. So I think as we grow more, we will need more funding if we have to grow the research component. No question about it.
I've been getting questions from the audience, and I want to remind people to keep sending them in, and we will get to them as we can work them into the flow of the conversation or save them for the end. Let's turn to Kelly Rinaldo of the Turner Syndrome Global Alliance. As I think your experience demonstrates, determination may be more important than money when it comes to establishing a center of excellence. Your order has Turner syndrome. What is Turner syndrome?
Absolutely. Thank you, Daniel. Turner syndrome is a chromosomal disorder. It's characterized by a complete or partial absence of the second sex chromosome. It affects about 1 in 2,000 female births. There are approximately 80,000 women, girls, and babies with TS here in the United States. In the diagram below, will show you that in a typical karyotype, has 22 pairs of chromosomes and a pair of sex chromosomes. In a female, obviously, we have 2 chromosomes, and a male has an XY chromosome. In a TS karyotype, what happens is a complete absence of that second X chromosome, so that the X chromosome is actually completely lost, or there may be a partial deletion of that X chromosome. Sometimes in a lot of our girls, there will actually be a combination where you have normal and abnormal chromosomes in the different cell types. And that we refer to as mosaicism. As most syndromes, a syndrome defines a group of signs and symptoms that occur that are characterized and characterize a specific disease state. But what that makes unique to our girls is, again, one girl with Turner syndrome looks exactly the same. So each one of them are faced with different challenges, just again, depending on how it affected their body. So just as we were talking earlier with the TS Alliance, our girls have a complex medical condition. Syndrome is typically characterized by short stature. A lot of our girls have cardiac issues with a bicuspid valve. There's a nonverbal learning component to it. Infertility is a big issue. Some of our girls experience hearing loss. Many of our girls have kidney or structural problems with how their kidneys are formed. And so when we're dealing with Turner syndrome, it's difficult because, again, there's a complex need of multi-specialists necessary to perform the care for them. Another thing that's interesting about Turner syndrome is only about 1 to 2% of our girls actually make it to live birth, meaning 98% of all pregnancies with Turner syndrome actually just spontaneously terminate before the little girl is actually born. In fact, most experts believe that 10 to 15% of all miscarriages in the general population are actually due to Turner syndrome.
Well, so much of what we're talking about with these centers are the importance of coordination of care. You know, I think people tend to think of that from a point of view of doctors sharing information, but prior to a center available to you, what was your experience getting access to the type of care you needed, the geographical complexity of getting appointments and going from one doctor to another? How difficult is that as a patient?
I don't think that our experience is unique to just Turner syndrome. In fact, they would say that most families with rare disease probably experience the same challenges that we face. You know, when Allie was diagnosed, of course, she wasn't diagnosed until she was 8, which I think a lot of families struggle with, of knowing or having that mom gut I'll refer to it, feeling that something is wrong, and continually going to your primary care physician, asking the questions, saying, hey, I don't think something's right here. And again, not that they don't want to help us as our primary pediatricians, but we deal with rare diseases. So many of the pediatricians out there never even seen a girl with Turner syndrome, so it becomes challenging. Once we were actually referred to a specialist and referred down to the hospital, again, it was challenging. I think one of the biggest challenges that you have when your child is diagnosed with a rare disease is you don't know the questions to ask. So if you don't know the questions to ask, how do you access that? Trying to find specialists, which ones do I need to see? And then once you've found them, trying to that they actually, somewhere in their professional career, have actually seen what your rare disease is. That's a big challenge. And I think the other piece of it is the isolation that goes along with having a child with rare disease. We probably seek treatment for 8 months before we ever met another family that had rare disease. That was only because we reached out and were actively trying to find families, because otherwise there's many families, and again, not only in Turner syndrome, but many of the rare diseases that go years, if not a lifetime, without meeting somebody else who faces the same challenges.
Well, after some effort, we're successful at getting Children's Mercy Hospital in Kansas City to establish a Turner Syndrome Center. You don't use the term Center of Excellence. You and your organization put no money into this. You convinced the hospital to set it up. What did it take?
Probably the best thing it took is perseverance. If you can move to the next slide, I can kind of give you an overview. This is kind of an overview of how the Great Heights Clinic, which is actually the name of the clinic that we have here in Kansas City, is called. My daughter was diagnosed in 2006. So in that year, kind of I spent the time just wrapping my arms around it. So one of the things that I realized quickly was it was very challenging to coordinate the care, access the care, know the questions to ask. And I have a background in the medical field, so I was already kind of ahead of the game, and it was still a challenge. So the first thing that I did is I joined the Family Advisory Board. Most hospitals nowadays will have some kind of either patient or family advisory board. This is where they engage families into helping them as an organization try to figure out how do we better care, how can we better our services. So that was the first thing that I did. Simultaneously with that, I started looking for my internal champion. I really think that for a successful clinic or development of a clinic, you have to have an internal champion. So I spent my time looking to figure out who was that going to be. As you see in the diagram, it all goes to creating a partnership. And that's the piece of it that I think is important. It's understanding what's the mission and goals of the hospital, what are the things they're interested in, and then the same thing when you're trying to find that champion. Then after the champion, because I have a little bit of a business background, I went ahead and put together a business plan and sent it, and we're discussing it with the hospital. And the business plan was more of how can this work in your existing structure with your goals, with your mission? How can we develop something that's really not going to cost you anything more? In fact, even argued back then, and now we have the data to support it, it actually benefited the hospital financially. It decreased the no-show rate. It increased the exposure. We now have families traveling in from 6 surrounding states to access care here at our hospital. To be honest with you, the providers really enjoyed the model as well.
Kelly, can we go back to the idea of the internal champion? What did you define an internal champion? How did you foster that relationship, and what role did they actually play?
I think the importance of when you're identifying your internal champion, I think the first, if you're new and you're saying, hey, I want to start this in my town or with my hospital organization, the first thing you have to do is find out who's the experts in your area, who already has a passion and an understanding for whatever your rare disease is. Then once you find that person, I also think it's important that you find the right hospital organization to try to partner with. You need to find one that's going to be open with that, I think the most disheartening thing would be to create this great resource, have a handful of or a group of families that couldn't access it because of their insurance or their economics. So you need an organization that can accept all payer sources, or at least the majority of them are open to that. The other thing too is you have to create yourself as a credible partner. You have to be knowledgeable. You have to be able to come to the table understanding, again, the challenges and the vision and the mission of the hospital organization. And we talked earlier, joining the patient family advisory board. And again, it's a marathon. I mean, it took me about, I guess it was 4 years from the time my daughter was diagnosed to the time we actually had our first clinic. I always think that I can get it done faster, but that's not the case. And so, and the last piece of it is create that demand for service. You know, one of the first things that we looked at, if I was going to go to the hospitals, to say, we have X number of families around the 6-state region that I think would come and access if you created it. You know, that was appealing to the hospital administration.
Well, again, you use the term center of excellence. You call this a stepping stone to a center of excellence, but you've talked about essential elements you see a center having. Can you walk us through those?
Should we move on to the next slide? Other things, and you're right, we don't call it a center of excellence. I think just as the TS Alliance at the beginning of the webinar stated, and then again out of Duke, we hope to have all different levels of TS clinics around the country. Our goal as an organization is for our families to have access to something that's within a 3-hour drive or travel commute for them. So we know that to have something that is truly what many people would define as a center of excellence may not be plausible. We do think it's important that each of the centers that's delivering care has some core basics. So the Turner Syndrome Global Alliance, we have actually put together this model that we've been utilizing as we help new pediatric centers get up and running, and that's called the Connect Care model. We've talked about the Connect because, again, it is connecting those patients and families with their healthcare providers, different specialists, and really making a whole person interdisciplinary type of thing. We believe that it has to expand a little bit further than that, too. Really, this model creates networking for patients' families to share their experiences, to meet other people that are dealing with the challenges that their child might be dealing with this. We feel it's important that there's an education component, that the sharing of resources, ensuring that patients and families are knowledgeable, and also promoting self-advocacy, not only to the families, but to those kids as they transition to adulthood, understand their care at an in-depth level. The C for Connect stands for Comprehensive Coordinated Care, and that coordination between multi-specialists. When you deal with rare diseases, it's not unusual for you to have 5-10 specialists that you're trying to coordinate that care, really in the hopes of that the providers are looking at you as a whole person. And then the T on that is the transition. It's important. It's just one of the biggest challenges, I think, across the United States that we find right now is a lot of great resources for pediatric and a lot of funding to support pediatric. So many of our kids with rare diseases are living past that pediatric. And so how is that care being transitioned to adult care providers? Are enough out there? So having a really solid model for that is important for us as well.
So you're the one patient representative on the panel today. How has the center changed the care your daughter and other Turner syndrome patients area get, and how has it provided maybe unexpected benefits, such as connecting you and your daughter to other patients and their families?
I think that's a good point. To the next slide, we can talk about that too. Ask many of our families, the model of care that we've created and that ability to get the coordinated medical care and kind of move towards research initiatives and stuff is very important to families. But I would guess that if you ask and poll our families, 80% of them would tell you that the networking component, that creating that connection both for themselves as parents but also for their girls is just as important, if not more important in some cases than the coordinated care. And it really takes that model of from being isolated to a community and allows us to develop that community both inside the clinic as well as outside the clinic. You allowed us this medical home model and this national resource. The model is now being duplicated. We allow physicians to come here to Kansas City and they actually spend 2 days with our team. So they don't have to recreate the wheel, but having that access to that care within a 3-hour to you and not having to travel hundreds of thousands of miles away to access care has been a big benefit as well too. And then the next piece of it too is our next step, which is we're now networking those clinics so that we can create research initiatives, research opportunities, and truly just a stronger voice for us as parents to say, our girls deserve more. And that's been a big challenge for our community in the past.
We have a number of questions from our audience, and we're going to get to them shortly. You can continue to send them in as we go, but let's bring Carrie back in. Carrie, patient groups can serve many important roles in working with centers of excellence, but one of the things your organization does, in a sense, is keep them honest. You talked about your review process. Can you explain the whole application and review and evaluation you do for clinics?
Absolutely. We have a very thorough application process. That application can also be found on our website. The application itself, the first-time applications reviewed by a clinics committee. That's a committee of peers, other clinicians or nurse practitioners that work at existing clinics. The clinic committee makes recommendations of which new potential TSC clinics will be recommended to our science and medical committee, and then they're approved ultimately by our board of directors. The other thing that we do is based on, and if you can reference the slide here now, based on how many core standards or gold standards a clinic meets, they'll have to report or reapply every 3 years, every 2 years, or every year, depending on which standards that they meet. So it is an ongoing process of evaluating through self-reporting, because the application is self-reporting, how the clinics are meeting a certain standard.
Well, what does that do for the patients you serve?
I think the detailed information about what a clinic is able to provide by specific specialty, by the number of patients they serve, we have this all very transparent on our website. They know that clinics are regularly being evaluated. Comprehensive care, again, so vital to our community, as you've heard Kelly describe as well. And having access geographically, very important. Further, one of our gold standards is to allow for a clinic ambassador or a TS Alliance volunteer to be in the clinic during clinic days. And that gives our volunteer the ability to talk with newly diagnosed families or families that want to connect. Something Kelly also mentioned, that networking component of rare disease clinics and what's so important about them. Our constituents also have the ability on our website to submit a form complimenting a clinic, lodging a complaint, for which we are able then to discuss with the clinic some of the concerns coming from our community.
You're also in a unique position with these clinics. Do you do things to foster collaborations or cooperation or establish some type of best practices between these centers? Well, what role do you see for patient advocacy groups in that regard?
So, we host regular meetings annually with our clinic directors. Either it's at the American Epilepsy Society or in conjunction with patient conferences or research conferences. We brought together groups of clinicians to work on natural history database. So there's a subset that work on that, and then they meet monthly and discuss those best practices. We have another subset of 5 clinics that have come together to form a clinical research consortium. So they're working very closely on clinical trials and then adding clinics with the trials that make sense. So we do foster that collaboration and best practice sharing.
From a clinician's perspective, what role do you see patient groups playing?
These were very eloquently described by the other two panelists, and I think they are, in a way, the beginning and the end. They the ones that inspire us to start these clinics, and they are the receivers of the monitors of the care, the guidance they provide is very essential, and I think the that develops between the physicians and the patient groups is key to these rare diseases in respect to the clinical aspects and provision of care, as well as with respect to research and raising awareness of the disorder. For example, with AHC, this disease is very often misdiagnosed as epilepsy, and these patients continue to be misdiagnosed as epilepsy. So raising awareness of the disease is very important. The spectrum of the disease is enlarging, and again, that raising awareness of that increasing spectrum, so that more patients will be recognized for what they have, as well as enhancing research. The research in AHC was and advances were only made possible through the parent organizations in the U.S. and in Europe, and by bringing researchers together that otherwise may not have been meeting together, and having annual meetings that were spearheaded by the parent on the organizations, and so it's not just providing funds and providing inspirations, but actually they have provided leadership in making things happen with respect to research also.
Let me bring some of the questions we've had in here because I think they tie into these issues. When you set up the clinic, this is for any of our panelists, questions about working closely with patient organizations, what challenges and how did you overcome them?
Well, I can tell you one challenge we faced was the clinicians we wanted to work with are all very busy, and they have like long waiting periods to see any patient. So to try and get them to be able to make time which is coordinated for the patient, so that the patient does not have to make 10 different trips and they're coming from across the country. I mean, it doesn't make sense, of course. Even if they live in town, you don't want them to do that. So that was a major challenge, and many clinicians basically were very anxious about making a commitment and then not being able to fulfill it. But I think by motivating them and basically having this camaraderie about doing something important and making a difference for patients that we all care about, we were able to overcome that. And,
if I heard the question correctly, and Carrie, you've dealt with so many different clinics, maybe it's best directed to you, but ever conflicts between the clinics and the patient groups, and are there challenges in getting them to work together? And if so, how did you overcome those?
I think, working together on things like the clinical consensus guidelines, where clinics are coming together, we're asking them to be our research specialists when examining what are best practices and sharing those is extremely important for building a culture of collaboration and teamwork. Have there been times where there have been disagreements. Of course, there always are. Our group also helps facilitate partnerships, and so how we overcome those. And how we overcome those is looking at the greater mission of our organization as a patient organization, but ultimately the benefit to those that we're here to serve, those individuals and families that are living with these diseases. I just want to go back to your previous question, too. Overcoming challenges within a clinic, part of that is the coordinated care. And I agree, having a person identified in a clinic to coordinate that care is hugely important for overcoming that challenge.
Well, at this point, I'd like to bring someone else into the conversation. We're lucky to have with us today Stephanie Oki of North America Rare Diseases and Senior Vice President and General Manager of the U.S. Rare Disease business of Genzyme. Stephanie, are you there?
Brim, thank you.
Hi, Stephanie. I apologize, Stephanie is only available on audio. Stephanie, you've had many years of experience working with groups setting up rare disease centers of excellence. I'm wondering if you could weigh in here with what you've learned over the years about effective ways to set up a center of excellence, what works, what doesn't.
Sure would, and I'll try not to be redundant to some of the excellent content that has been shared. So a couple of things that we've learned, and working together at Genzyme and many of the other biotech companies as well. Finding the person that will be the engine behind your needs is important. So a couple of things are this. If you find that one person that is interested in helping and sit down and write out all of the specialties that your condition could possibly intersect with, such as an orthopedist, a nephrologist, there are elements like Carrie and others have mentioned, that really need to come together to provide comprehensive care. And then what I've seen done is you systematically go to those departments and either talk to them one-on-one or simply have a grand round. And we found that the more interesting aspects is if a patient and a healthcare provider work together. So if they put, a face behind the name of your condition. What we've also found very effectively, it's not just enough to go and talk about the disease in a grand rounds or lecture type setting, but end it by saying, wait, who of you will help us? Who of you will work with us to provide comprehensive care? And typically, having that ask, just asking, is so important. There is so much you can do. And I tell you, it is definitely worth the time because the FDA has recently made some comments to the rare community that is very helpful if you're looking for a treatment. One is collecting the natural history data on patients is so important. So patient groups and centers can work together because the FDA, if you're fortunate enough, is at some point going to be looking at a therapy and saying, okay, is this good or bad? What do we have to compare it to? So that is critically important. Another item is making sure that you have a good way to diagnose that is somewhat widely available, or that you share that information with others so that they are looking. I also really like the idea of doing your statistics. So, for example, if you, one time working in Denver, it didn't seem like there was much interest at the University of Colorado, but when we mentioned there are likely 156 individuals in this area that are walking around with Gaucher disease or whatever the condition is, and they need your help, really kind of quantifying and painting the picture. The other thing that I would also mention is keep yourself informed. keep your medical records with you or on a jump drive, and the Center of Excellence can help you. But when you go in, many times you're going to be much more knowledgeable than the people at the center and sit down and educate them or be at the ready if there's an acute condition that way you can quickly and efficiently, so for example, if you end up in the ER or at your internist, you can help inform them very much more likely. And also one... Yeah.
You've been involved in a creation of a number of these. Can you bend the learning curve for our listeners and tell us mistakes to avoid?
Absolutely. So mistakes to avoid is, I think, we are all people. It's been said that physicians are very busy, and chipping away and persistence is important. So I think that even though it could be caught in your throat, if you can set aside the emotions and explain the need and be patient, we have found that sometimes physicians will say, no, I'm too busy, but that might not always be the case. So making sure that you know when to check in and the like, and also mistakes to avoid, don't try to do this by yourself. For example, Dr. Pram Mistry, who is at Yale, is a world expert in Gaucher disease. And what we try to do is do things by ourselves. When you partner with a key thought leader and have them, because they're interested in the data and providing comprehensive care, Dr. Mistry has set up satellite clinics all over the United States, as well as Tim Miller, because they reached out working with a company or a patient advocacy group. So don't go it alone. There are many things that you can do. One last thing I would say for the Center of Excellence is once you've got something up and running, everyone's time is valuable. So asking them, is it possible for when a patient comes in, we can organize the appointment so that you're getting everything done in 1 or 2 days versus, say, 16 appointments spread out over 2 months. There are practical aspects, and we're happy to help share any of them toward better health. It's an important time.
So we've had a number of questions, and I throw this open to our entire panel, but there have been a number of questions about establishing common multidisciplinary center template models that any or all disease organizations can build on. I think to some extent, if we turn to Carrie, how transferable do you think the standards you've established are to other disease categories?
I think they're very transferable, and all of the information is housed on our website, so anybody can come in and access that information and adapt what you need to your own organizations. But I think the idea of a template model is an excellent one, especially in our rare disease community.
And at the same time, there are questions about multiple organizations working together. The listener says that they find a lot of desired collaboration, but often there's a strong geographical preference that is to do things in my backyard. Have any of you had this issue where you've had to overcome that type of conflict between organizations?
This is Kelly with the Turner Syndrome Global Alliance. I think one of the challenges is I think we have to come with the patient advocacy and remind everybody at the end of the day it's about our individuals, our family members, our loved ones with a rare disease, and yet be respectful of institutional needs and goals and objectives and stuff like that. I think if you come from the go, at least we have, is when we go out and reach out to new key partners in this, and we clearly state up front, guys, you can't own it. This has to be shared. If you want to be at the table, you have to be willing to share this not only with our own disease states, but with other disease states. Our and provider community has been very receptive to that.
The other question has been raised about whether centers can address more than one disease, whether there are centers of excellence that treat a cluster of disease. Stephanie, I don't know in your case if you're dealing with a lot of lysosomal storage disorders. Are they tend to treat a single disease, or are they treating multiple diseases?
Daniel, you know, this is an excellent question, and I would say that once it's like a critical mass of momentum, and to Kelly and Carrie's points, once a center, physicians and healthcare providers in simple fact are typically humanitarians, and many of the physicians who started out, for example, setting up comprehensive care for one disorder, they've got it down, and they are absolutely willing. They understand it, and also the more patients a particular center sees, the more knowledgeable and the nuances of dealing with a condition are important, and that is transferable. So, for example, when we worked with the University of Utah, Dr. David Viscaccio mentioned that because they've been involved with lysosomal storage disorders and they became knowledgeable and connected to others around the country also treating, their level of care for hemophilia, for NF1, for many genetic disorders, it has raised the bar because something has been created that didn't exist before. So I think, you know, we can all help each other. We are all in this together, and, you know, alone a condition can be rare, but together the approach is the same. People with rare conditions often have many comorbidities and need that comprehensive care, and centers really are proud, and it differentiates them. So always knowing what is in it for the center.
Well, we're short on time. As a last thought from each of you, what advice would you offer for either a patient advocate or a clinician want to establish a center of excellence? Let's start with Carrie.
Thanks. What I would recommend is partnership. You have to have that champion in your community, but you also have to have that champion in healthcare provider. And working together, they can really create a strong center that best meets the needs of those living with your rare disease.
Mohammed, how about you?
Optimism and passion, because now the time is right for many of these rare diseases to be addressed as we would like, and I think from the basic science point of view, from the realization of the FDA, the NIH, and the patient groups, that this is the time to address them, and we have the social, the medical, as well as the scientific elements that will kind of propel us, and but it will need these will need a lot of work, and optimism and passion is key to the success, hopefully.
Kelly?
I would agree with Katie, Daniel. I think the partnership is the key to building a partnership. But I add to that you have to have patience. It won't happen overnight. I think any of us that are on the webinar today would tell you it took probably a little bit longer than what we had imagined it would. But it's possible. And as an advocate, I would tell my daughter, I said, what's the worst thing that they can tell me no? That's not it definitely the perseverance that goes behind it.
Stephanie, can I ask you to weigh in here?
To build on the excellent suggestions of everyone, I would say give feedback to the center. We all want to be appreciated and know that our efforts matter. And letting the center and the healthcare providers of the site know how much they're impacting your life and your health, that provides motivation and is just a way of seeing the good. And thanking them, I think, just builds the partnership to the points that have been made, and frankly enhances the quality of the care.
So I'm going to sneak in one more question here, which we didn't get to, but there's a question about the bill funding for these centers, and that asking if anyone can share the ways to find the money to begin. But I think one of the most surprising things about this conversation is how much happens without having the money. So how essential is it having some seed funding, and if it's essential, where do you get it?
You know, Danny, I do have a comment that could be of use to folks. One thing that we have learned in hearing from the payers, you're right, this hasn't come up so much, but what we've learned from payers, and specifically the medical directors of big payers, they want to know what centers have expertise. So sometimes the sites that have been talked about, they may be quote-unquote out of network. So it is possible with persistence that you can get to a medical director who understands that the most cost-effective thing is going to someone who knows about the disorder. And that can be a win for the center because they do make money the more patients that they see, and it also then removes the barrier of, you know, there's nothing more painful than knowing there's a site out there that knows about your condition, but your insurance at first blush doesn't allow you access. So it can be financially very positive for the center and certainly good for patients.
We're out of time, but I'd like to thank our panelists for sharing their insights today. Carrie Luther Rosbeck, President and CEO of the Tuberous Sclerosis Alliance, Mohammed Makati, Chief of the Division of Pediatric Neurology at Duke University, Ronaldo, Founder and President of the Turner Syndrome Global Alliance, Stephanie Oki, Head of North America Rare Diseases and Senior Vice President and General Manager of the U.S. Rare Diseases Business of Genzyme. Thank you all for your time and joining us today. I'd like to thank today's sponsors, Alexion, Genzyme, and Shire for their support for today's webinar, staff of Global Genes, and Kitty Mastro for her great work putting together and coordinating today's program. You should join us for our next webinar, Optimizing Your Loved One's Learning and Potential at School, which will be held on July 29th. Hope you'll join me every week for our Rarecast podcast, which you can find on Global Genes Rare Daily or on SoundCloud, iTunes, or Stitcher. You can continue the conversation with us by following us on Twitter. You can find me at DS Levine and Global Genes at Global Genes. And as you seek to learn more about rare diseases and connect with others, I encourage you to explore the many resources available on the Global Genes website. On behalf of Global Genes, I'm Daniel Levine. Thank you all for joining us today and being part of today's webinar.
Thank you all.
Thank you so much.